I like to look at primary assessment as yes, no, fix it. Do they
Okay.
have an airway? Yes, no. They better have an airway before you move
Fix
on to
it.
breathing. When you walk up on scene, you're looking at somebody. Is that person moving? Is that movement purposeful? If it is, well, they have a heartbeat of some kind. So
Right.
talk to them. See what the response is. That'll tell you a lot. Do they have an airway? Are they talking in 2-word sentences? That kind of a thing.
The views expressed on EMS In and Out are solely those of the hosts and do not represent any affiliate agencies or employers. This podcast is for educational discussion only. Always follow your local protocols and consult your medical direction when applying any clinical practices discussed. Hello and welcome back to EMS In and Out. I'm one of your hosts, Kyle Goodnight, and with my other host, Rob Moyers. How you doing, Rob?
Good. How are you, Kyle?
I'm
Good to see you
fantastic. I'm super happy of being here with you again. We've discussed this topic since the beginning of our conversations, and I'm really excited to get into it. Before we get into that topic, don't forget to like, share, and subscribe. This is episode number 3. So share your friends. Rob just shared with me that one of his people that he knows is starting to tell other people, and this is how EMS In and Out is going to grow and get big. So tell us what we're thinking about talking about today, Rob.
So we had a conversation about response time versus transport times, and we kind of really focus on the back end of that, of how we are no longer trying to trend in the idea of diesel therapy and waiting on scene. How do you treat and stabilize on scene? And we're going to talk a lot about a few different topics about that, especially with kids a little bit later. But in that topic, we did kind of glance over what happens initially and like your response time and the beginning of that. And then when I did talk to my coworkers, one of the things that they had mentioned was, because they're field training officers, and they're like, man, we're looking forward to your next one. We've been telling our students about this. And it really kind of clicked something, because I teach a lot of early in EMS people. So, brand new EMT, whether you're coming from the streets and you're learning what EMT is through the state, whether you are coming through the academy. I help teach in our academy. I was a field training officer. So understanding that beginning part of an assessment, and then being able to determine what you're staying and playing with. You know what I
Right.
mean? So,
Right.
so the idea, the whole thing is, I'm sure you've heard this before, sick versus not sick. And that's kind of the idea of, it's not necessarily stay and play anymore. It's sick versus not sick.
Right. And with that being said, the sick versus not sick, and it applies to, they've got a really good pediatric version of that, and we're going to talk about that later, but it still applies to the adult too. It
Yes.
really does. If you get in there and you're like, oh boy, this person looks like crap, you usually say it a little bit differently when you see them in your brain, but it's, and things like, doing a 12 lead on scene compared to loading them up and getting them into the back of the truck before you do a 12 lead. A couple concepts behind that is, wait a second, how long does it take me to actually get them into the back of my truck? The operation, the protocol I operate under, and I think it's pretty well standard across the country, is they want a 12 lead in 10 minutes or less.
Sure.
Well, it can take 10 minutes easily by the time you, and they go off of like the time that you get on scene. Like, is it, or by the time you mark, because we mark that we get to our patient.
Mhm.
So they may see that in retrospect and say, hey, you didn't get a 12 lead until like the 20th minute. What was going on?
Sure.
Especially when it's a true, and that's for chest pain, of course. That's not like, oh, I'd like to get a 12 lead on this person. Okay, they're not complaining of chest pain, so let's get them to the truck and then do one. That's different. Like when the call comes in as chest pain, the complaint is chest pain, you get that sick, not sick feeling. Whether they look sick or not, when they have that complaint of chest pain, that 12 lead is very important in a stable environment too, not bouncing down a highway as well. So,
Right.
So those are the kind of things that I think of when it comes to adults. Expand a little bit on the beginning stages of teaching your students what you do and how you approach this whole, assessment of sick, not sick.
So as part of the team for our EMS, our EMT course that we do it for Cleveland EMS and for Cleveland Fire. Patient assessment will make or break a national registry exam, and they're going to base everything that you do off of your ability to assess. So if you can really nail down assessment, and assessment is 5 things.
Yeah, I was going to say, what are the 5
yeah.
things for assessment? That's right.
Exactly.
Good.
Scene
We're in the
size
same
up,
brain.
and they change depending on medical versus trauma. So you have scene size up and primary assessment are number 1, number 2 all the time. Trauma, you have that rapid exam that comes after primary assessment, and then the next 2 switch. So if it's a trauma, your second one is secondary assessment, followed by medical history, followed by reassessment. Medical patient, that medical history is that much more important, right? So the idea of, okay, we all know gloves on scene safe. You don't say that, you don't pass, right?
Right.
But then what happens? And I'll take, for example, the chest pain with the 12 lead. If I walk up on scene and vision is the first sense that I'm using when I walk up and they look like they're having a STEMI, it is super important to get that 12 lead before I move that patient, because not only am I going to get dinged on it if I don't, but now we have the ability to send that to the hospital, who's then going to take a look at that and prep a cath lab. And this is going to do nothing but help the patient. It does nothing for you or I to scoop them up, throw them in the back of an ambulance, get a shitty 12 lead, send it to a hospital where then what do they have to do? Get
Redo
another
it.
12 lead.
Yeah.
Right. So if I can walk into a hospital and an ER and the doctor takes the baton from me versus starting over, well now I'm doing my job in the highest,
Right.
possible way.
And one of the things I just thought of the other night, because I'm sure Rob does this thing too, now that we're really starting to think of topics and things we want to talk about. I was sitting in bed the other night, couldn't fall asleep, and I started thinking about the whole, 12 lead on scene compared to in the back of the medic compared to at the hospital. So and this is where it's great to have two different points of view. I come from the hospital world originally. I remember those days. It was 10 years. It was a level 1 trauma centers and high acuity type of hospitals. And
Uh-huh.
I do remember people coming in with STEMIs where our doctors will do another 12 lead. And that always like baffled me, because I'm like, they sent in a 12 lead that says they're having a STEMI. Why are we not all of them? I mean, not all of them stop in a room and get assessed by a doctor in a new 12 lead. I mean, I have pushed a cot right into CT before from the ambulance, where
Yes, yes.
I bypassed all rooms. Doctors walking down the hallway, we're giving them report, and we go right into CT. I've done that, but I've also done it before where they're like, you got to go to trauma 1 first, and then someone is, where's the 12 lead? And they're getting a 12. I'm like, guys, we already sent you a 12 lead. It doesn't look good, and they still get it. Like, what's your experience with that? Is it kind of, it just happens sometimes, and it's just what we have to deal with, or what?
I think it really boils down to the previous care that they've seen you give. And if it's the hospital or doctor maybe that recognizes you and you're on a hey doc, kind of a thing. If I walk into I worked on the west side. So if I walk into a west side emergency room near west side, and especially Metro, I have, people that I'm married to that work there.
Trust you? Yeah, yeah.
Yeah, so I walk in and I say, "Listen, this is what I got." Or I call it in and say, "Listen, this is what we're coming in with." It will be a pass the baton kind of a thing. But let's say I get a call on the far east side, they don't know me from anybody. It's like it's so I do feel like there's that relationship, and I feel there's a lot on your character and past practice type stuff that matters. Anything that and just then what I could tell people is those experiences that you don't think matter in emergency rooms when you see doctors and you see nurses, and maybe you just didn't get that IV that day, or maybe you didn't send that 12 lead that day. That stuff matters. It matters to the patient that needed that 12 lead
Right.
seen, further along in their career.
Yeah. And that's funny that you say that, because when I first became a paramedic, I worked as a respiratory therapist at the like simultaneously. I do 12-hour shifts at the hospital, 3 of them a week, and I'd work 24-hour shifts at the medic. And I had 11 to 11 shift. And there were times when I would tell my EMS people, "Hey, listen, I can't stay over because I've got a shift." And basically maybe about noon one day, here comes my boss on the medic, because she had to fill my spot, and this was a
Mhm.
private ambulance. And I looked right at her as we're taking this patient into the trauma bay, and it's a respiratory distress patient. I'm like, you see what I mean? I'm like, I can't just like stay over for you. I've got other responsibilities that are important. But
Yeah.
and it's no different than the time when there was one time when I came in and the therapist knew who I was, and the charge nurse and the doctor knew who I was, and the nurse was newer, and she didn't know who I was, and I started giving a report, and she started chomping at me about stuff, and the doctor and the respiratory therapist just laughed, and they're like, because she was questioning me or something like that,
Mhm.
and
Right.
they're
Right.
like, Kyle, it's okay, we'll take care of it. And I start
Yeah.
walking out, and I hear them say, "You don't know who that is, do you?" Because I was,
Reputation.
yeah. Yeah,
Reputation
exactly.
means a lot, man. It
It's
does.
not always, but it's just funny when you're in those situations at the different hospitals that you're used to. So yeah, that's funny. But yeah, so when it comes to other things that we would do on scene that matter, so 12 leads are important. What about diabetics? I mean, people that's a unconscious, could be a stroke. Like talk a little bit about how you walk somebody through the assessment of that diabetic or that stroke or that unconscious person that getting that blood glucose is actually really important on scene because I've got a couple of
Right.
stories about how that almost bit people in the butt.
I do like to do it in order of importance. So
Okay.
so the way that I teach primary assessment, bleeding is always first, right? XABCs is a new thing. But I like to look at primary assessment as yes, no, fix it. Do they
Okay.
have an airway? Yes, no. They better have an airway before you move on
Fix
to
it.
breathing.
Yeah.
So and I could really, when you walk up on scene, you're looking at somebody. Is that person moving? Is that movement purposeful? If it is, well, they have a heartbeat of some kind. So talk to them. See what the response is. That'll tell you a lot. Do they have an airway? Are they talking in two-word sentences? That kind of a thing. Are they talking gibberish? Are they telling you, leave me the F alone, get out of my house? Versus they're not moving. And where I start with that one is always going to be pulse breathing, right? And I like to equate that in because we've talked about ventilators with the idea of understanding respiratory distress versus respiratory failure recognition. If I walk in or you walk into a house, somebody's in respiratory distress, well, we know that they have a pulse, right? So I know exactly what to tackle. We're going to be tackling respiratory in that call. But you brought up a hypoglycemic patient. That also looks like somebody that's in respiratory failure. That looks like
Sure.
somebody just had a seizure.
Or
That
a
could be
stroke.
somebody in cardiac arrest or a
Or a
stroke.
stroke.
So you have to think about, okay, well, what are the killers going to be? And you have to weed out the killers. So what I feel like happens is we nail respiratory distress. We walk into that call, if we have our ventilator, maybe some BiPAP, CPAP, depending on the
Ambu
patient,
bag. Right.
ambu bag, depending on what's going on, right?
Right.
But failure, if you're not following those ABCs, you might be missing out on the cause of the problem right away versus and which is a little bit more of a killer in that state. If I'm in respiratory failure with gross mental status change, that is way more of an immediate killer than getting a blood sugar. So I tell people rule out the killers, rule out the things that are going to actually kill your patient before you can even get them to the truck. And then you move on to the next step. Because if I can fix this mental status with respiratory, we know it's a respiratory call, or at least partially a respiratory
Right.
call, right?
Especially with kids, like we're going to talk a little bit more about kids later too. But if you don't support that airway, most kids don't go into cardiac arrest unless it's a respiratory failure issue, and that's going to be very important for later on.
I'm so glad you brought that up because a lot of what I teach came from a terrible call that I had, which I won't get into because of like HIPAA violations,
Sure, sure.
but it was a pediatric failure that matched that just slumped mental status.
Hmm.
Somebody that's breathing 14 times a minute doesn't necessarily mean they're breathing great. So you have a situation where, understanding what's going on physiology, and that patient's going to go, their peri arrest. Especially you walk in, you got a wide complex bradycardia, that kid's gonna rest soon. And that's where it's like, it's so important to get some breaths downrange on
Yeah,
that
and
patient
supporting
versus
that airway is going to help that heart. Right.
yes, yes,
Yeah.
yes.
Well, and one of the things you mentioned earlier and was part of our pre-talk is Rob and I, despite people's thinking of how spontaneous this sounds, we do a lot of talking pre-hand, and we probably have two conversations to every podcast so far. Well, but one of the things he mentioned that really stuck out to me is when you're doing the eye test as you're walking up, determining if they're sick or not sick, do they track you? Do they look at you? Is that a pediatric looking at you? Most pediatrics are going to be a little, or are they staring off into space? So talk a little bit about how you train your EMTs and anytime you train people about assessment about the eye test per se, or what their responsiveness is when it comes to looking at you. Like, I
Yeah,
just
and
thought it was a
that's
really good topic. So
absolutely, yeah, and that kind of goes down into that purposeful movement, especially with kids, because you look the younger the kid, the more you have to alter your assessment. So, are you looking at how do you determine a mental status with the kid? Do you ask a 2-year old, like what month is it? Who's the president? So can they be distracted, consoled? Are they looking at you? Should they be looking at you? You know what I
yeah,
mean?
yeah,
Should a strange, should somebody be looking at a stranger coming in their house with a loud microphone and a first response group of maybe 5 to 6 people, and they should be like, what are you doing here? Or help me, I'm having this problem. If I don't have that and I have to find the problem, it's super important that I go through the motions, especially as a young medic or EMT. When you haven't quite gotten that groove yet, that is how you miss important things, and unfortunately, that's how patients can, have a really poor outcome. So eye movement, is the patient in a way, whatever age, and you have to obviously know age appropriate stuff. Are they doing what they should be doing at that age, at that moment, in that situation? And you should know that in 5 seconds. And that's how quick it should be. 5 seconds. I should be able to walk in and know my general impression of that patient, right? And then I go hands on. So my general impression, they're not moving. I better know. What's the worst case scenario? They don't have a pulse.
Right. Sorry, dog's
No,
barking.
it's all right. He
My
backed
two
he
pups,
backed me
my
up.
my two pups wanted to be in the room with me during our recording,
I must have
and
said something good. They must have agreed.
oh, they did, yeah, they heard one of my. I have 4 dogs, so I had 2 of them downstairs and 2 of them up with me. So,
All
but
right
yeah,
on.
so sorry for that interruption,
No, that's great.
everybody. I like.
It's
I'm gonna keep that in. I mean, that's real life. That's what That's what it is. So when it comes to the altered mental status person that you're doing that eye test on, how do you teach the importance of what they should really focus on? You said you said, are they sick, not sick? And then it was, can I fix it? Yes, no, tackle it. Or what was it? Yes,
right.
no. Yeah, yeah.
So,
So
so, so I say yes, no, fix it. So,
yes, no, fix it. Yeah.
normally in primary assessment, you can't move the breathing if you don't have airway, right? So you have to go down that route. And an altered mental status because of hypoglycemia is obviously a medical emergency. An altered mental status because of somebody that's breathing 4 times a minute is a little bit more advanced of a medical emergency. So you think about the acidosis thing. Now we'll get into the groovy acidosis idea. Metabolic acidosis patients, for the most part, can survive longer than respiratory acidosis because they have a way to off gas acid. My respiratory patient does not have that ability. So they're going to die quicker than the acidosis versus the diabetic patient who they're going to be able to sustain that extra 5 minutes before I rule out the killers. And those killers are going to be no airway, inadequate breathing, poor perfusion, no pulse or lack thereof of a pulse, to the radial spots. And then as you get into your career, you start to really kind of see the common things that cause those. If I can't feel a radial pulse, well, what are the reasons? Shock. And then what does shock look like? Are they always, they're usually diaphoretic. So you put these pieces together in your career as you go through. And I walk in a house and it's a chest pain call and they can barely look at me. They're pale diaphoretic. I need a 12 lead on them so I can be sending that. That might be a little bit more diesel therapy ish, but I'm going to make sure that I'm, getting that patient stabilized before, I'm feeding it out of there.
I do remember now what I wanted to ask you about. It's when you talked about, when they get into their groove. You said about when you get into your career and you get into your groove, like, tell everybody that maybe the younger listeners about what they need to fall back on if they get on scene and they go, oh my gosh, I can't remember anything. Like what am I supposed to do? Like you mentioned it in our pre-talk about how you want them to default to the learning. And then as they get into career, speak about how you teach when you come to that.
So I don't like people to cut corners. It's primary assessment for a reason, right? It's you're supposed to be doing that initially. So you're walking up on a patient, let's say that is altered mental, not moving, and the first thing you're pulling out is a pulse ox. I don't care what their numbers are. I just need to know if their heart rate is fast or slow. So if you follow the course of the teaching into it, right, and you start to really understand, like if I do something away 100% if you can, the same way every time, you will then develop a groove based on not only muscle memory, but your recognition of disease as you go out there. So you might not know what a STEMI looks like or somebody in septic shock your first 6 months, but maybe 5 years in your career, depending on your call volume, you're going to know what a STEMI looks like, a true inferior STEMI when you walk in. So that might, in that situation, I'm not saying I'm cutting corners, but it's going to direct me right to that. You know what I mean? Before I'm walking in, it's like this is my first septic shock patient, and I don't know why their heart rate and blood pressure are this, but I know that they are this. I need to fix the patient, and then
Right.
you learn from there.
Well, and that kind of goes to that groove. You find your groove not only within yourself, you also find that groove with your crew. We run a 3-person crew, and I was on a crew for 9 years, the same crew. And don't get me wrong, we had vacations and time off where we had different people in, but you could always tell when the three of us were, and if we ever got the band back together, and we for whatever reason were working on the same truck even years after we worked together for those 9,
Mm.
like it was like we just know we just knew we had a
Oh
flow.
yeah.
We
Yeah.
knew what we were, everybody trusted everybody, and everybody understood what this person was stronger at than this person. And sometimes on, like, when it comes to, I've got a crew right now that I've got one person that's so much better at dealing with an angry person than me. Not that I couldn't do it, but I just know he's better. So he gets teed up if I know that we're coming into a combative patient, or a combative or potentially combative family member. You know,
Yeah.
tell me a little bit about, like, how you train, how to assess not only the patient but assess the scene. Like, talk about that, because I think that's something that we don't talk much about, is like an ongoing scene and assessing. I've been almost blindsided a couple times by people that I was not expecting to get physically in my face about some stuff when I told them that their family member doesn't need to go to the hospital. Somebody got right in my face and was like, "You will take her," and I'm like, "Whoa."
Yeah, those situations are dicey. I obviously could work in a little bit of a dangerous area. Um, it's we set the scene we walk into a house 99% of the time. If you walk into a house and you are respectful of people and you talk to them and you're kind, 99% of the time, even if there was an issue, you can get and you can develop ways to have discussions with people where I want them to see that I have a uniform on and then forget I have a uniform on right at the same time. Like, I don't want to come in looking like looking like a first responder, but I do. I want them to know that I'm a first responder, but I'm also another person that's there to take care of their family member, right? But there are safety things that we teach. We do. We started. We paired up with a suburb who did some self defense training. There was a news story. What One of our members got attacked on a scene, and
Wow.
after that, it prompted us to say, "Hey, listen, are we doing enough to train for that kind of stuff?" We did a lot of training when ketamine was put out there, so there was a lot of self defense. And I don't think that there's enough emphasis put on de escalation. De escalation training is huge.
Huge.
So and maybe it's not even in your department. Maybe that's an outside department type thing where you have a company that specializes in that, and you put people through scenarios, right? It all comes down to training, unless you have 30 years experience.
Yeah,
so
yeah.
so it just all comes down
Right.
to, are you guys training this stuff? Are you getting real feedback? What metrics are you measuring to determine whether you even have the right idea going forward? So
Yeah.
yeah.
Yeah. Well, and that kind of leads me to one thing when it comes to, I was telling you before we got on today about something I had just read recently. It was pediatrics, and this can also get us back into the pediatric assessment triangle. I know we want to go over, and I can do a little screen share. But one of the things they found in this study of what is it? I've got it pulled up here just so I can make sure I quote it properly. In a study of 1,225 pediatric severe TBI patients, kids who died before reaching the hospital had shorter scene times, not longer. So this was a post put out by Dr. Antevi on his Handtevi LinkedIn page, and it was just it caught me. When I read the title, the title was EMS on scene associated with reduced dead on arrival status among pediatric patients with severe TBI. So this and it's a good conversation, because that's a specific, it's a specific thing that happens to kids. Actually a very common thing because of how they have big heads, and when they fall, when they're on playgrounds, they ride their bike, they get hit. So, we do see, there are a decent amount of pediatric head trauma, football players, people that are in sports, that kind of thing.
Assaults.
Assaults, yeah, I mean, geez, yeah,
Yeah.
exactly. So each one of the things is one of the, and I won't read everything about this, because we can put the full study. I've got the link, and I know Peter won't have a problem with me putting this link back to his content. He likes people to read his content, so I don't think he'll have a problem with
And can
it.
I ask you, did it
Yeah,
say reduce mortality with longer scene times for EMS or shorter?
prolonged. So it says here. Let me just share the
Okay.
screen. I'll start
I just
there.
want to make sure I didn't hear that
Yeah,
incorrectly.
no, it says EMS time on scene associated with reduced dead on arrival. So the longer you stay on scene and stabilize that patient and treat that patient, the more survivability they had. instead of
I got
load
you.
and
Okay,
go
yes,
and
yeah,
diesel,
yeah.
because you forget things. You for like, oh crap, we forgot to do this. We forgot to stabilize the airway or what have you when you just load and go on these kind of kids. But this is what the data showed. Each additional 1 minute on scene reduced dead on arrival odds by 8%. It's pretty significant.
That is significant.
Survival probability peaked at approximately 10 to 12 minutes of scene time. So thinking 3 minutes, let's go. These people lasted, survival was better at 10 to 12 minutes instead of 3 minutes and gone, right?
I
Um,
is it the same reasons that, are we trying to reduce those secondary injuries, the
I think
hypotension
yeah, and that's
and
what it. I think that's what it boils
hypoxia?
down
Yeah.
to. The load and go instinct is deeply embedded in trauma culture, of course, but the data suggests that for pediatric severe TBI, time you spend stabilizing on scene may matter more. So that's
Yeah.
yeah. So
Stabilization is huge.
yeah,
And that's another thing, especially new medics. I always have to take into account that, when I'm teaching a new medic that might be working with a new EMT. And I'll just take the subject of ventilators, for example. You put this big box in front of somebody and they start panicking. Well, I tell them what should already be happening if you're pulling on a ventilator. Like, they should already be ventilated.
yeah. They should already
So
be yeah.
in all aspects, get basic life support squared away. Buy yourself that extra time to figure out, okay, what's the next move? Like, you know what I mean? So
Mhm.
if you take that time, that extra 2, 3 minutes to stabilize that airway, stabilize that breathing on that pediatric, TBI, now you start looking at, do I need to get an IV or an IO? Because, if that patient crashes, I need access. And it's a lot easier to get it while you're standing there, making sure that they're not hypoxic, making sure they're not hypovolemic, making sure that they're not vomiting, because that happens a lot more with kids with head injuries. So, all of these things, making sure that you have that squared away and
Yeah.
stabilized to the best of your ability
Yeah.
before you start rolling down a fast, bumpy street is probably a lot better. Obviously, 11% is what you're saying. I mean,
Well, yeah, and well, 8%, yeah, and
8%.
per minute, yeah, per minute. And one of the things, we always talked about the golden hour and all that stuff for adults, but I still think it still boils down. I mean, I'm not sure this, the discussion of this study and how it reflects to adults and their, head trauma or trauma in general. Each individual thing is its own thing, but it what we're trying to help everybody that listens to EMS in and out is that critical thinking. One of the things that Rob and I spoke about before we ever started this, we said we want people to hear what we say and not take it as gospel and not, I mean, hear our experience. Yes, here are tricks of the trade. Here are insights and what is burnt and what has helped us in the past. But it's all about that critical thinking. And when you're critically thinking about that topic, you can also critical think about something else. Okay, well, is the golden hour going to be good for this person if I can't establish an airway? Well,
Right, right,
then let me take that minute or 2 minutes on scene and establish that airway so we don't have aspiration problems in the adult, in the pediatric patient, because that's ultimately, you know, what's going to really be their demise is because now you've lost the A of your
right,
XABCs, right? So,
right.
but
And
yeah,
and again, we go back to younger people. Or I don't want to say younger people, because there's some older folks that might be brand new into this, but younger in the job, developing that critical thinking isn't something that everybody just has that can pull out of their pocket, right? So until you do develop those skills, going back to the teaching, going back to the default setting of how you do your assessment, matters. And another data point we were talking about, that doesn't make any sense. If you're 2 minutes out from a hospital and you can get a patient whole blood, and the whole blood is at that hospital, the studies show not only is there increased survivability, but they need less blood a lot of times while they're at the hospital. And
if you
it's
can get it
kind of
started in the truck, right?
yeah.
Yeah,
So
yeah,
and
I
I
did
could
read
be I
that.
could be down the street
I did read
from a
that.
level one trauma center.
Yep.
It does not help the patient a lot of the
For
times if
diesel,
you don't
right?
go through. Yeah.
Yeah. It actually helps the patient for you to establish that bloodline and get that blood started because it's important. Yeah. I mean, and that kind of, that kind of leads to, the whole topic of of that not prolonged scene time, but stabilizing the patient. That's very important for pediatric respiratory distress, as we've talked. And when it comes to that, one of the things that we're going to do before we close out here is I'm going to pull up the pediatric triangle pediatric assessment triangle, and we're going to kind of walk through that because you could kind of take that one and kind of put it into the adult world too. So it's a very
Yeah,
good basic thing. But
sure.
talk a little bit about the pediatric respiratory distress or respiratory failure. We touched a little bit on it earlier, but talk a little bit about that when it comes to why would it be important to stabilize that person, and what we have on the horizon, that could change the game with that.
Yeah, absolutely. Recognition of distress and a failure for kids is huge. Capnography, which wasn't a big thing back in the day, is a good driver for ventilation, mental status. But we know that respiratory distress into failure is the highway for cardiac arrest for kids. Understanding and using that pat, and like you said, we could use it for adults too. It's just you're looking at skin color, you're looking like appearance. Are they moving right? And you're looking at basically your respiratory type status, your circulation status from
Here,
afar,
I'll
and
bring
and
it up.
and right. So, I know that pretty soon you have something coming up, a seminar regarding pediatric CPAP, and understanding that stopgap of what else is there out there. And you could do blow by, you could do a nebulizer if they take it, a BVM if you have to, or intubate. But are there more tools out there that fit the different models for kids and what
Right.
you're looking at?
And that's the thing what that we're starting to really teach when we're out and about and when we're doing the webinars and whatnot. And having we I did one of our medical directors or pediatric medical directors a few months ago, we did a paramedic refresher for people down in Kentucky. And the biggest thing is it kind of this is one of the first things we show is this right here,
Yeah,
because we don't know if everybody's using this, but this really simplifies what we're looking at. And what it all boiled down to is that you're going to start on the left at that appearance, right? What's their tone, what's their interactive, everything that Rob spoke about earlier. Are they tracking you? Are they paying attention to you? Do they look hazy? Are they, if their speech, if they are able to talk, are they talking to you? Can they answer your questions? Like you said, with little small kids, they're not going to say who the president is, but are they saying hi? Or are they shying away from you? And it's purposeful. Okay, like a crying shy kid is, I'm happy. On a
yeah,
sick crying shy kid, I'm totally fine with that, because that means that they're acting normal. Then the next
yes,
thing you looked at is work of breathing. So this is something that, of course, the first one says abnormal breath sounds, of course, but everything else is actually more important when it comes to that respiratory distress. Is, are they gasping? Are they nasal flaring? Do they have retractions? Pediatrics, please, 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 for the love of God, expose their chest appropriately and appropriately aged to see if they've got any intercostal muscle movement. If they're diaphragmatically breathing, if their belly is flopping out every time they breathe in, that's not normal. They're using that big diaphragm to actually pull air into their lungs. They're having problems. Because if you don't get the work of breathing under control, that's where we have a problem when it comes down to what their circulation is like. Their circulation may look good, their pulse ox may be great, but their work of breathing is the most important thing on respiratory distress. And what did we have with respiratory distress patients in the past for pediatrics? We kind of talked about it earlier. We had three things: diesel fuel, get them to definitive care faster. We
right.
have blow by, whether that's oxygen or nebulization, and then we had BVM or intubation, which I combined to put together. Because if you're bag valve masking a kid, you're probably also thinking, should I be intubating this child? Well, now we've got a fourth thing, and that's what the webinar that on March 30th you can come. I'm going to put the link in the show notes. It's put on by GEMS. It's a full CE credit put on by CAPSI. You'll be able to get an hour worth of pediatric credit for it. But we're going to basically walk you through not only the pediatric triangle, we're going to walk you through case studies of people here in Central Ohio that have been put on pediatric CPAP and what their path looked like. And the doctor's going to talk about it. We're actually going to have a very special guest to come on and talk about an incident that they were a part of and how they viewed it. It's going to be a very interesting hour. It's going to be very informative. We have a tool in the industry that is being proven after case that it is that fourth thing that we were always missing.
Yeah, yeah, I agree. I agree. I think, coming from the world, and I know that you had a little bit of it as well, understanding the development of CPAP for adults, how how amazingly changing that was for them. Not, so many did not need to go on a ventilator at that situation. And now, seeing BiPAP being used actively in the field. As a respiratory therapist, I'm sure 20 years ago, you weren't having people come in with a patient on BiPAP, potentially epi, nebulizers, Meddraw, and mag.
Yeah. Yeah, yeah, they've already taken care of the first 10 minutes of a severe asthma attack in the ER.
Yeah,
And once again, it's like that blood discussion earlier. Why not stay and make sure those get started, and it shows in the long-term care of that patient, rather than use diesel fuel because you think that the hospital is going to be like our medics in the proper areas with the proper medical direction and protocols. Our medics are little tiny ERs, and we get trained and we get permission and we get medical direction to do these kind of things that we used to be only for the hospital setting. And
yeah.
I think that's what a lot of people don't realize. And not every department's doing it. I get that. But we have to advance departments that are doing it are also the ones that are going around and talking about it and telling their
Mm.
peers and going to the conventions and talking to the other medical directors that have to have some form of understanding, or somebody that's doing it. For example, when it comes to blood, you guys are doing it. Central Ohio, not doing it yet. We're right on the cusp. And I've talked to several medical directors, and they're said we're just trying to get the last few things figured out, right?
Yeah.
So it's going to be a game changer once that, and I feel that blood in the field is going to be standard of care in the next 5 years. What do you think?
Oh, yeah, yeah. Especially the military is working on something now that is it's reconstitutionable blood. So it's basically like powder that you put saline back into.
Yeah.
That's not FDA approved yet.
Right.
But I mean, imagine having a shelf like a non-rebreather does, and you could just have it on your squad, right? The understanding of why, like the physiology part of this job is super important. Why does blood work that early? Why does it matter when I'm looking at a kid's work of breathing that I know that kid has less in the reserves? We know those muscles aren't meant to sustain that kind of stuff, and they don't have as much reserves as your 60-year-old COPD patient who's been living in this status for a long time. So understanding the importance of, like, man, we really need to turn this kid around before we can't.
Right.
And that's a
Right.
big deal. How do you turn around somebody before you can't turn them around? And
Exactly.
knowing limitations of, elderly versus pediatric versus, a normal, like, middle-aged person that might survive something a little bit longer than most.
Right, exactly. So, but yeah, I mean, we didn't talk super in depth about everything that we touched base on, and of course, if you want to know more, reach out to Rob or myself, or by all means, reach out to different studies, and Google is a great thing. You can type in things like, "Oh, tell me more about blood," and Google will find you articles that talk about it. If you want to find out more about pediatric CPAP, sign up for the GEMS webinar. It's free. It's 1 hour, 1 p.m. Eastern. The link will be in the show notes below. Sign up for that. I've got my medical director, myself, and another gentleman, Rob Glaze, who's going to be on the webinar. From our expertise, Rob and I are the ones that actually went to NAMSP last January and spoke about it at Dr. Antevi's thing. So it's you're going to be learning from people that are doing it and who have fine tuned it. Other things, like when it comes to your assessment, if you're in school and you don't feel that you're getting the assessment, um, teaching, ask your teacher to teach me more about assessment. How can I get better at assessment? Teach me a
Yeah.
flow. Do you guys do any teaching for assessment? Do you have any quick things? I know the one you said earlier was a really good one. I've never heard that one before, but
One of the things that I make sure that I do, and whether it's a new EMT in school trying to learn the stuff, or whether it's somebody like learning ventilators that aren't comfortable, I have to set the time aside, and I have to say, listen, I'm just going to set time aside, and we're going to practice. Scenario based practice is the best way to go. You can talk and show slideshows until you're blue in the face. Give them patient scenarios, right? Get hands-on stuff. Throw them some curveballs. Allow them to fail in your presence in training, and then teach those moments. You learn a lot more than failure, right? From failure sometimes than you can from anything else. So it really does fall on the instructor. It falls a lot on the field training officer. We rely on our field training officers a lot because we teach what we teach in a classroom, but then the real actual hands-on teaching goes into the field, right?
mhm.
So you really should have that idea of an instructor is just like, My job, I don't walk in here and I teach a pep class and I sign you off a card. It's like I need you to know why we're teaching this stuff so we can just raise that standard of knowledge and
Right.
care.
And that's one thing that Rob and I have actually gone through too. There's, you know, being part of our education group for our separate departments. I know that he's probably gone through it. I've gone through it. And it was really cool when I first started, learning it. It was the follow up, the debrief. Like when
Yes,
they
yeah,
first started teaching me the debriefing, I'm like, oh, so there's a structured way to debrief. Like I have always done debriefing because when I was in medical sales and I was also running on the truck, I get people and say, "Hey, Kyle, I put in an easy IO the other day and blah 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 happened. What the heck?" And I'm like, "Okay, tell me more about it." So I had already been debriefing, but I didn't know the structure and I didn't know like the importance of it because ultimately I'm like, "Okay, well, instead of telling me that it failed on you, tell me what happened." Like share with
sure,
me. Like, okay, did it stop halfway in? Okay, did you look and see if there was scars? Well, yeah, they end up having a titanium knee. I'm like, well, that's why we need to go back to our training and remember that if any scarring that's a null and void point for that
yeah,
area. So case in point, I had a gentleman come up to me and said, "Hey, Kyle, we almost pediatric CPAP'd a kid again the other night." And I'm like, "Okay, tell me about it." And he started telling me about it, and as he was going, and he was telling me, and I'm like, and he's basically telling me everything that I trained him. He said we looked at retractions, it was just a little bit. We did go ahead and do blow by med neb on them, and it started turning them around. There was air movement, so it wasn't a silent chest. Like he was going through all this stuff that I had trained him, and I'm just sitting there. I'm like, you know what? And he's like, so could we have done anything different? I'm like, no, dude. I'm like, you did the right thing. You stayed and assessed and stabilized
yeah,
before you loaded and went. And that's the whole message here. Stay and stabilize. You're not going to want to be excessive. Come on now. Like common
sure.
sense, stay and stabilize means stabilize. If stabilize is getting an airway, then stabilizing is getting an airway. But it was what was really cool and what I told him at the very end right before we stopped our conversation. I said, "You know what I like the most about everything you said to me?" And he goes, "What?" And I said, "You were critically thinking. You
Yeah.
were clear. You and your partner were critically thinking of the next helpful stage for that pediatric respiratory distress patient. That whether you put them on it or not, that's the most important thing because
Yeah.
you critically thought why you should or shouldn't put it on." And I said, "I'm proud of you guys." I'm like, "You guys are doing great." And that would have been the second one that crew would have put on a kid in like the last 6 months. So it's
It's great.
it's
Yeah.
getting it's getting the thought process and in their head and making sure that that assessment is solid, that they don't overlook anything, and they take their steps that they learn. And what the good news is he is one of our newer medics too, so he's kind of fresh out of school too. So
But
he
you have to
helps.
empower them, right? You have to
Yeah.
empower them and for confidence, because their confidence is going to come from your background, like your again, your your history and whatever you're doing matters. If they come in and they're like, man, this person doesn't know what the hell they're talking about, you're not really going to get a lot of confidence from them. The more that you do that, the more that you have those debriefs, the more that you sit and take the time to say, hey, listen, come up to my headquarters for an hour or two. We'll go over the vent. We'll go back over the training. We'll go over the stuff. When I see that happening and then they get excited about it, and then I see them 3 weeks later, be like, that thing that you told me about capnography and pulmonary embolisms. Oh my
Oh my
god, I
god.
just saw
I
it. It
just
was
saw it.
crazy.
Yeah.
It's like that's
Well, and just the reverse of that. When it comes to some of these newer medics and newer students, sometimes I need to know what they're being taught. Like, I mean, like you and I both, we're 20 plus, year veterans, 25 year, almost 25-year veterans of EMS, not just healthcare. And there's stuff that there's being taught out there. I mean, well, you may know more because you're an educator. I mean, you're in that world, but I'm not in that world. So there'll be times when they come in and they say, "Oh, well, we learned it this way." And I'm like, "Okay, tell me more about that." And they don't realize that they're teaching me something that I can teach the rest of my group when I go to the next station, right?
oh
So,
yeah,
yeah, I
yeah.
mean, and
I,
if we're seasoned medics, we need to make sure that we don't always just write them off of they're green, they don't know what they're talking about. Like,
if If you get it, and that could go both ways. If you get there's a new technique out there for innovation. There's the snail thing. I've never done it. I was a straight guy. I didn't even like the video things. I'm old school, right?
Oh, I've
But
I've I've
I
already
get
drank
somebody
the
that comes
Kool-Aid of
in,
video. I've drank the Kool-Aid of video. I'm good. I'm down.
and it's crazy. We're doing airway training, and I get one of these young Thundercats coming in with this new training. I'm like, man, that's hot shit. That's pretty cool. I like that. That's really cool. Or you're in a situation where you're dealing with somebody who was taught poorly, and now you have to break either bad habits or
Right.
reteach some stuff that
Right.
to get them to where they need to be.
Yeah.
It's our job as an educator to be able to assess that and then try and turn it around, or like you said, adapt. Be like, hey man, you show me how you do that again. I want to teach that. That's we'll put that in the training.
Yeah, exactly.
Yeah.
Well, Rob, I think our time is pretty much up. I mean, unless you have anything else you think we need to talk about, I think we touched base on pretty much everything that we
Yeah,
wanted
I think
to.
it's gonna be great. Yeah,
Yeah,
I think
I mean, you
by
and I,
this time,
like a lot of people have heard, Rob and I we could go back, we could like change gears and go into a whole nother conversation. But we like to keep these to under an hour, so they're very obtainable on your way into work or while you're working out or something, so you can get more nuggets of information as you go through your day from the stuff that we talk about. And like I said, like we've always said before, you want to come on and talk about a specific area that you feel is important to you, or to run by us, and we're going to have people on all the time. Don't hesitate to reach out. Our contact information is on our YouTube channel. The email is on our YouTube channel. You can find us there. Email us questions. You can always put questions in the comments. I really highly recommend that, because I look at comments on a weekly basis, sometimes a couple times a week, as I'm loading the next episode. So the comment area is going to be a very good and fast way to communicate questions about certain, and we know which episode it's attached to as well. So that leads to the subscribe, share, leave comments, tell more and more people that are in this industry, getting into this industry, seasoned veterans, have them tune in, have them subscribe on YouTube, have us like all that stuff.
can you say one more time? Did you say the date, time, and spot that that webinar is going to be on?
Yeah, absolutely. So the pediatric CPAP webinar is going to be on March 30th. It will be at 1 p.m. Eastern. It is put on by GEMS. So the Journal of EMS, they are the ones that are putting it on. It is a full CAPC accredited, and you'll have to register, of course. The link will be in the bio. Hit that link, register for it. It'll send you updates of when it's going to be on. And we did a dry run late last week. We did a dry run. It's going to be really informative. It's going to be really well done. We're going to have multiple camera angles so we can show equipment, so we can show what we need to teach everybody. And once again, really stay around for the whole thing if you can. The special guest is going to rip your heart out. I'm just telling you. We've got a special guest that's going to really say why this is so important.
I'm looking forward to seeing that, and I'm actually looking forward to like a follow up with you, maybe next podcast after that happens, if the timeline goes off. Talk about your experience doing that. Hit more onto that information. I think that'd be a great segue. So I'm looking forward to seeing you on that. That'd be really
awesome. I appreciate it, Rob. Well, thanks again, everyone, and all of you that have tuned in to listen to the In and Out podcast. You're one of your hosts, Rob Moyers, right there with as always, the hoodie.
Yeah, it's my go-to. This is my suit. This is my
I
suit
had
jacket.
my hoodie on earlier. I changed it for whatever reason. It was getting hot, and then when I was walking by to come and get on this, I was like, oh crap, I need it. I don't want to be on my t-shirt, so there was a shirt that was hanging on my one of my stands here in this room, and I just grabbed it and put it on, and it ended up not being my hoodie. My goal was for both of us to wear hoodies every single episode. But
yeah, that would have been, see how long it would have taken people to figure that one out.
Yeah, people figured that one out, and people are like, oh my God, these guys are dad joking us, so.
Right.
All right, everyone. Thank you so much. Rob, take care. Nice seeing you again. And
Same
we'll
to you,
talk to you guys next week.
See ya.
Thank you for listening to EMS In and Out. 2 systems, 1 profession, real conversations. If this episode challenged your thinking, share it with someone on your shift. And remember, keep learning, keep questioning, and always follow your local protocols and medical direction. Please like, share, subscribe, and hit that bell so you'll be notified anytime new episodes drop. And as always, stay safe out there, and we'll catch you on the next call.